it would be in the general population. I would say that if you have a patient in which you've maxed out on lifestyle changes, diuretics, beta-histine, and they're not doing well, there is some evidence in the literature to go with a migraine therapy. And I personally use the calcium channel blockers as a test try to see if their symptoms are controlled. And you'd be surprised that many of them just, magically a month or two later, their symptoms are well controlled. So I would recommend you try that, especially if the patients have concurrent migraine symptoms. Steroids are helpful. Oral steroids have been shown because there isn't, as we said, an inflammatory and autoimmune component to Meniere's disease. So it's worth considering in flare-ups. Now, if you follow that, about 75% to 80%, and probably even more of patients have good control of their disease. They go, symptom-free or almost symptom-free for months and occasionally years. You will have the occasional seasonal effect. So, I live in a temperate climate. My patients do tend to show up in clinic around, probably late September, early October, when the weather starts changing. And what are we now? Mid-April, probably in a couple of weeks, I'll start seeing more and more of my Meniere's patients. And there is actually evidence for that. The house clinic had, Dr. Jennifer Derryberry had a few articles about treating allergic rhinitis and allergy symptoms in order to help better control Meniere's disease. So if you want some reference, you would look under her name. Now, but what about the other 15 or 20% of patients who do not get better? What do you do for them? And what you do for them, again, depends on what you want to achieve, right? This is a disease that affects hearing, that affects balance, and it has a fair bit of comorbidity with it, and it affects the quality of life significantly. So anything we want to do beyond that, I think we have to think of certain principles. One is try to preserve hearing. Yes, we do have patients with single-sided deafness who live fairly well, and we have ways of rehabilitating single-sided deafness. But if you can preserve hearing on that side, then you would probably be sparing the patient some morbidity. The second thing is try to preserve residual vestibular function. They may not have a lot of vestibular function present, but if you can preserve it, and if you don't just go to an ablative therapy, try a more conservative therapy first, then your patient will probably be better off. Now, this discussion about preserving vestibular function, you can say, well, what if it's not a big deal if they have a hypofunction on one side? We do actually have patients with the labyrinthectomy that we operate, for example, for vestibular schwannomas, and we send them to vestibular rehabilitation therapy, and they do well. Probably true, but that's not your first step that you want to go through, because especially if you have an elderly patient who has other comorbidities, they may not fully recover in terms of true function and balance function, even with an intensive program of vestibular rehabilitation therapy. The other issue we're going to think of before we go to a destructive therapy is that there are cases of bilateral Meniere's disease, and the literature says anywhere from 5 to 50%. And these cases don't show up with both ears at the same time. Most of them is a sequential. It's a time issue. So you wait, and a few years down, they just have the second ear affected. So you got to consider that before you ablate vestibular function on one side. Other treatment options are the intratympanic injections. We'll be talking about that. And then, of course, the surgical options, which are endolymphatic sac surgery, vestibular nephrectomy, and surgical labyrinthectomy, which are beyond the scope of today's discussion. What is the rationale for intratympanic therapy? Essentially, we're placing a medication through the tympanic membrane in the middle ear, and that medication diffuses mostly through the round window membrane into the perilymph and gets absorbed into the inner ear. There is some evidence for diffusion of some of that medication through the annular ligament of the stapes at the oval window and through some of the embryonic fissures that in some patients are preserved and not fully obliterated around the cochlea, and therefore the medication gets in the perilymph. The issue here is a bit the round window permeability. So we're not really putting the medications directly in the inner ear. We as therapists, we're putting that medication into the middle ear through the tympanic membrane and hoping it will diffuse through the round window membrane. And the round window membrane in humans consists of three main layers. There's an outer epithelium, there's a middle connective tissue, and there's an inner endothelial layer. And if you look at some pictures, for example, endoscopic pictures on the left of your screen, you see that some, for example, like picture B, in the circle, there is a clear round window membrane that you can see. It's that grayish area. whereas on the A version has a layer of fibrous tissue over it. And similarly, and on the right side of the screen, these are surgical pictures, again, from patients undergoing cochlear implants. And you see also a thick fibrous layer on the overlying the round window. This is another study that was done in Japan that they used intratympanic gadolinium and then analyzed how it was absorbed in the inner ear. And they saw that 5% of ears had absent permeability and 13% had poor permeability, where the gadolinium compound did not go really fully into the inner ear. Why are we talking about this? Because a lot of the variability between patients could, in part at least, be attributed to problems in technique, in the position, and absorption into the inner ear. Now, getting the compound in the inner ear is one thing, and how it diffuses into the labyrinth along the perilymph is another thing. Now, for example, these are, if you want to, if you're interested in this topic of drug delivery and drug diffusion in the inner ear, probably one of the best worldwide references is Dr. Alex Salt. He has several papers about that, looking at different compounds. This is from one of his papers that looks as gentamicin and dexamethasone. Along the x-axis is the distance along the scala tympani, and the concentration of the medication is along the y-axis. And you see that the further in towards the apex of the cochlea you go, the lower the concentration of the drug. And this was done for several of the medications. This would become especially important as we discuss the steroids in a second. Now, what is the rationale for gentamicin use? This is a chemical labyrinthectomy. A chemical labyrinthectomy was initially described, I think it was 1948 or 49. It was initially administered through systemic streptomycin, intramuscular streptomycin. However, streptomycin is not selective. It is both vestibulotoxic and cochleotoxic, so there's a high rate of hearing loss. If you give it systematically, you can get bilateral hearing loss and loss of vestibular function. So with time, people switch to gentamicin, which is more selective. It is less cochleotoxic, so less hearing loss, and more specific for the vestibule. It can also be deposited more readily in the middle ear and diffuse in the inner ear. And it destroys the sensory epithelium, but also the dark cells producing the endolymph. Now, what's the rationale for the corticosteroids? As we said, there is now strong evidence for an immune-mediated reaction in the inner ear in Meniere's disease. There are high levels of autoantibodies in the endolymphatic sac, and these could be affected by steroids. Steroids do also affect the sodium-potassium ATPase and potentially the potassium ion transport into the endolymph and help keep that ionic homeostasis in the endolymph. And we do know that steroids increase the aquaporins, which are the intracellular connections, and then that stabilize also the ionic composition of the endolymph. The other question in talking about steroids, and that goes back to the whole absorption and diffusion, is which steroid? There's one gentamicin, but there are several steroids on the market. We talk about dexamethasone, we talk about methylprednisolone, but again, you see I cited some of Dr. Salt's work in the bottom right. You really have to know which compound you're using and what is the actual compound, meaning if you say dexamethasone, the commercially available preparation is dexamethasone phosphate, and that's the different compound than dexamethasone, and the studies about its absorption and diffusion are different. But to make a long story short, if you look at the literature, in general, there's a sense that methylprednisolone may have a better perilymphatic distribution along the cochlea and slower elimination. But however, if you have ever used methylprednisolone, you know that it is fairly painful to inject because it has an acidic excipient and it causes a fair bit of irritation and pain when deposited in the middle ear. Any questions so far, or, I guess I'll keep going.
Please.
Okay. So let's look at outcomes. We've talked about the why, we've talked about the how. We still, have to look at what happens with either of gentamicin or dexamethasone. And there are quite a few studies. If you look, if you put a search in PubMed for intratympanic therapy in Meniere's disease, you'll get around 510 articles. I think when I did that yesterday to check. And the data, again, are all over the place. This is a review that was recently published. I'm referring to it because it's fresh. So again, if you look at gentamicin studies, it looks like gentamicin has a slight advantage in vertigo control over steroids, might have better results in oral fullness. but there's definitely, because it's ablative, there's more vertigo and nausea after the procedure and a higher level of hearing loss. Conversely, steroids, they have a better hearing outcome, okay? Some of those outcomes didn't make a big difference in the long term eventually, because probably of the natural history of the disease, but the effect of steroids is shorter lived, so you might need more retreatment. I think the more important takeaway from that review, if you look at it, however, is that this is a recent review. Like I said, there are 510 probably papers in the literature, and they were able to select only eight studies to look at and to extract meaningful data. So that speaks a lot to the quality of literature that's out there. If you look at some individual studies, this, for example, a randomized controlled trial that was published in The Lancet in 2016, and the outcomes are about the same for intratympanic gentamicin, intratympanic corticosteroids, looking at 2-year outcomes. I'm citing some different studies. I'm not going to go into the individual studies because, like I said, there are hundreds. But what we can say, looking at all the different literature, and to give you just an idea and a sense of what you should be doing and what you should be considering, is that there is a large variability in the results. It depends on the medication, like what we talked about, for example, with the steroids, whether it's DEXA or methylprednisolone, what dose of the medication you're using, what protocol are you using, and we'll talk about some of the protocols in a little bit. And then again, what are you measuring? Is it objective endpoint? Are you looking at some tests, some calorics, the presence of nystagmus, or just following what the patient tells you? And are you looking at things in the short term versus the long term? This is an interesting study that keeps getting referred to. This was in 2004. They did a meta-analysis of all the gentamicin therapy studies that were published until then, and divided them into 5 groups. Series where the gentamicin was given daily for multiple days, weekly, low dose, which is a diluted therapy, which was given intermittently, a continuous infusion, meaning putting a tube in and using gentamicin drops, or titration means giving an injection, seeing how the patient reacts, bringing them in after a week, seeing if they have nystagmus, and giving more injections as they need to. And again, if you look at the balance of both, the multiple daily, which is the most aggressive therapy, has probably the highest rate of control in terms of vertigo, but they also had the highest rate of hearing loss, probably around 30-some% on average. And the take-home message from that study, that meta-analysis, is that titration probably gives you the best balance between vertigo control and a preservation of hearing, which is about 12 to 13% of hearing loss in this situation. So again, if you look at all the studies, roughly there are similar outcomes for gentamicin and steroids. And gentamicin may have an edge in the short term, but in the long term, it doesn't make a huge difference. Steroids, I think there is no controversy as to the fact that they have been proven beneficial. Again, the most recent guidelines published last week, they say that we should be offering steroids, or at least we may be offering intratympanic steroid therapy to patients with Meniere's disease. There are no significant side effects for intratympanic steroid. There are very rare cases of systemic absorption and systemic side effects, but that's really, really rare. Probably the most common side effect is a perforation rate of 1 to 2% when you're injecting it repeatedly. The other thing is that you do have, again, we go back to the imbalance and the disability that happens after gentamicin. Gentamicin is more aggressive, it is more destructive, it is a chemical labyrinthectomy. So these patients might get more disequilibrium, and they have an issue with balance and rehabilitation in the long term. This is, I think, fairly reasonable, at least in my opinion. This is the international consensus statement algorithm for the treatment of Meniere's disease. Starts with lifestyle counseling, low salt diet, low caffeine, beta-histine diuretics. That protocol had pressure pulse treatment, which is the Meniere's disease. The recent American Academy's guidelines say that we should not be offering the Meniere's disease because the evidence is nowadays considered against this therapy. In this protocol, and I tend to agree, this is my personal practice, is I offer the intratympanic corticosteroids next because it helps at least preserve hearing, if not recover it. It does preserve vestibular function, and it does work. I think there is no doubt in my mind that it does work. It's not 95% effective, but it does work. And then if those patients don't respond, then we move on down the ladder or up the ladder. And depending on the hearing, we can either present them with intratympanic gentamicin or more conservative surgical treatments such as endolymphatic sac. And I know there's some controversy about the sac surgery, but this is one of the options. One last word, this is my last slide. What is the future of treatment? We're not, we've been talking about the same compounds over and over through the years. There are some exciting breakthroughs. There's a company called Autonomy, which has done a lot of research on a compound now called Otividex, which was initially a lot of the research, or the research code name was Auto-104. The initial US study, phase 3 trial, which was called the AVERT-1, revealed no significant difference. And the AVERT-2, which was in Europe, was halted for a while. But as I was checking their website, as you can see on the right side, the phase 3 trial in the AVERT-2 is back on apparently. And this was confirmed by clinicaltrials.gov, which lists all the ongoing clinical trials. So we'll wait to see what comes out of this. So the Otividex is essentially steroids in a special suspension. This is a suspension that's liquid. And then as you inject it in the body, when it warms up, it solidifies, and it's a slow release formula that you inject in the middle ear. There are other compounds that are under study. The literature is not strong enough yet, but there are some immunomodulators or other anti-inflammatory, and that's probably the way we're heading. And I think there will be more and more, you'll be seeing more and more work towards better understanding the pathology and the underlying pathology of what we now call Meniere's disease or Meniere's syndrome. With this, I hope I've given you some direction, some understanding of the rationale of the intratympanic therapy in Meniere's disease, and we'll have a few minutes for questions.
Dr. Al-Farghal, can you hear me?
Yes.
Can you, I saw that you have a question. Do you mind asking, Dr.? Can you help us?
Yeah. First, thank you very much, Dr. Bassim. I think this is one of the best lectures on Meniere's disease and the intratympanic injection. It's based on evidence-based practice and knowledge. So the question, I see that in my experience, which is more than 20 years in the field, that proper management rarely succeed to stop the progression of sensory neural hearing loss. And it's maybe just to slow it, but in your experience, could the proper management prevent the progression of sensory neural hearing loss or no?
Well, I think, as you say, if you look at the data in general, overall the patients will progressively deteriorate slowly with the hearing. But I think if you catch the patients early, so the younger patients that come to you, and these patients, I'm really, really strict, and I kind of scare them a little bit about losing their hearing. I haven't been in practice that long. It's only 11 years for me right now. But so far, I think if you're fairly strict, you could at least stabilize their hearing for a while. Now, I don't know if they eventually will lose their hearing, all of them, but you can stabilize and keep it in the, what we call the useful hearing. There's a better term for it that's escaping me right now. But, usable or aidable hearing for at least a few years. And that's what I was trying to convey, that, yes, in the long term, they may eventually end up with burnout disease. But if you choose a therapy, I'm not partial to steroids. I have no vested interest in steroids, but I have come to see it work, that it actually pushes that eventual hearing loss and loss of vestibular function a couple, 3 years down the line, which may make a huge difference for a lot of patients.
As experts, that we would like to hear that your protocol for, your personal protocol for the intratympanic injection of dexamethasone or methylprednisolone, and your personal protocol for the gentamicin injection. Is it a single dose? Is it a titration protocol? And if you are doing a series of video head impulse testing or vestibular testing for the titration monitoring?
That's actually an excellent question. Well, personally, I do. That protocol that I showed at the end, I showed it because I think, or today at least, I think that this is a reasonable way to go about treating patients with Meniere's disease. Even, and I would say, even if you notice, I'm going to put that slide back up again. Can you still see my screen?
Yes. We can see your screen.
Okay. You notice that treatment here for intratympanic therapy is put before the analysis of hearing. So even it comes before the discussion of whether they have good hearing or no good hearing. So I think if you fail the conservative oral therapy, whether you have hearing or not, I would like to try steroids on you, because if it can preserve that vestibular function, then you'll be a happier patient, and then we still have a lot of other options to treat. And what I tell my patients is, look, when I first meet them and I'm educating them about Meniere's disease, I say, I have treatments that are 95 or 99% effective. I can go in and do a neurectomy or a labyrinthectomy, and you're out of the hospital the next day. And I guarantee you will not have another vertigo episode for years and years, unless you get bilateral Meniere's disease. But, let's go step by step. It's a ladder. If you stick with me and you follow the law solve and the, lifestyle counseling, and we see each other relatively frequently, we are able to delay that inevitable decline. So I personally like the intratympanic steroids. I usually use dexamethasone. I think I'm trying to answer your question right now, because the methylprednisone is fairly painful. The concentration that we have here is 4 milligrams per mil, and I'm having some doubt, but I do see some success. A lot of the studies initially were made with a compounded preparation of 24 milligrams per mil in the US, but that's the one we have. So I use dexamethasone for 3 injections. I give them every other day, give or take, depending on where the patient is coming from and whether they can come, frequently back to back. The gentamicin injections, I give 1 and I wait. So in a way, if it's a slow dose / titration protocol, I keep in close contact with the patient. I have my staff call them a week and I see how they're doing. And I don't change anything in their oral therapy for at least a month before I make a judgment call. The other part of your question was, do I use objective tests such as VHIT, for specifically the VHIT? I don't because the VHIT is often normal to start with in the patients. And there are a couple of studies that, I didn't cite them here, that looked at the VHIT change after intratympanic gentamicin. There's a reduced gain of about 30% compared to the pre-therapy. But I don't think it's necessarily the best indicator. VAMP may be better, but honestly, I have not used it to monitor those patients. I don't know what your experience is on that.
Calorics.
Calorics, yeah, that's probably. But how many patients do you know that are willing to go back to calorics over and over again?
Agree. I just want to thank you because we're almost out of time. I have plenty of questions that have been listed in the chat, and I was wondering maybe we can have later on another Q&A session with you regarding this topic, if you don't mind. We'll talk definitely about it later.
Yeah, of course.
Thank you again, and for everyone. Yeah. Dr. Fagher, any last word?
No, I would like to thank Dr. Bassim. It's really an outstanding, very informative and up-to-date. So thank you very much.
Thank you. Thank you for organizing this. This is tremendously helpful. Thank you.
Thank you, sir. Thank you.